You know, he was in his late 70s and guy could barely walk. And he's like, Doc, I used to grab it with 2 hands.
Exactly.
And I was looking at him and I told him, sir, you tell me one cell in your body that looks the same as when you were 20 years old. Why do we expect, as men, why do we expect that our penises are not going to change? Well, in Puerto Rico, it's like, I believe there's something in the Caribbean waters, and we tend to be a little more open about sex. So
what do you think is in the water?
My wife will kill me for this.
There is an interesting article that you and I shared in the Journal of Sex Med concerning spontaneous erectile function recovery among young men with ED taking tadalafil.
Any guy who has even mild erectile dysfunction, I truly believe that they should be on a low dose tadalafil daily or every other day.
So I have a gentleman who's in his 50s, and I put a penile implant in. Happy patient, right? Always good to have. And now that his surgery's over and he's fully recovered, he asks if I want to go out for lunch.
Oh, come on. So what did you say? I don't know, Amy.
One of my favorite questions to ask men. Any idea what it is?
Oh, God, I have no idea. I'm scared to even go there. What?
Welcome to Fertility and Other F Words, the podcast that tackles fertility, sexual health, and everything in between. No topic too taboo and no question off limits. I'm Dr. Amy Pearlman, board-certified urologist with expertise in sexual, hormonal, and genitourinary health, and co-founder of Prime Institute in Miami, Florida.
And I'm Dr. Larry Lipshultz, board-certified urologist, specialist in men's health and fertility, professor of urology, Baylor College of Medicine, and chief of the Division of Male Reproductive Medicine and Surgery.
Larry, how was your week this week? Anything good? What you got? What you got, Larry?
In terms of patients and things?
Yeah, sure.
So I did see a very interesting patient.
Okay.
Tragic, but it's okay. It's a happy ending.
All right.
So this is a 26-year-old gentleman, comes to see me with a identified large scrotal tumor, testicular tumor, right? Now, what complicates this is at age 15, he had his other testicle removed for testicular cancer. So now he's got one testicle, right? I go to examine the guy, 26, married for 6 months. Nicest guy. So I go to examine him, and I did bring in something to show you.
Okay. Some eggs.
Yes. So
Thanks,
what
sir.
are eggs in Spanish?
Huevos?
Huevos, which also means testicle.
Seriously?
Right? Slang. All right. So no testicle on one side.
Okay.
This is the testicle he has. The entire light brown is cancer. Total, and I know this man knew that he had cancer for many months, and he didn't want to face it because he was newly married. He knew he was going to lose the testicle. It was terrible, right? So at the rim of the bottom of the testicle was a little piece of normal tissue on ultrasound. Now, I don't remember whether or not Taylor ultrasounded him or not, but this was on a routine ultrasound, I believe. So we had a little rim. So the plan was take out the testicle, see what's in this little rim, and bank it if we could.
In terms of sperm, you're talking about. So he could
banking.
have potentially a future biological child.
Yes.
Yeah.
And this was his only hope.
Yeah.
And quite frankly, I was pretty pessimistic because when you've got this much tumor, what's going on down here at the bottom? So testicle came out. We microscopically excised this area, took it to the lab, motile sperm. Right. So we froze 10 tubes of motile sperm. Fantastic outcome.
Yeah. So is a guy like this interested in having a testicular implant put in?
His problem was insurance. Very, very, very bad insurance. In fact, we had to do the case some other place because our hospital would not take his insurance. But anyway, everything worked out, and he now is on testosterone and orchid, no testicles, but he has a future potential for having children of his own, which I think is really exciting.
Yeah. So let's talk a little bit about if someone has a testicle removed. Do you ever put testicular implants in?
Yes, but that's patient's choice.
Yeah.
We tell them that, they will have an empty sac on one side if they don't want a prosthesis, but it's very easy to slip in at the time of surgery and much easier than having to go back and do it at another time. So I would think 80% opt for testicular prosthesis.
All right, so let me ask you this question. Do you think there are guys that have their testicles removed that wouldn't have considered future fertility implications. Like they wouldn't have gone in to see, oh, is there any sperm that we can salvage from this testicle? Do you think that's commonly offered?
Commonly. I don't know. I mean, I think, no, I don't think it's commonly offered. I think if you're in a metropolitan area with lots of, surgeons who do a lot of more complicated surgery, somebody's going to tell you, you could have sperm banked.
Yeah.
But the problem with this man, and it's a lesson, is that he let it go too long. He did not, he knew that there was something going on, didn't want to face the fact that there was more surgery ahead because there would have been more tissue to bank had he gone in earlier.
Well, fortunately, when it comes to testicular cancer, it is very curable when caught early.
Yes.
Yeah.
Now, I think he had, or he did have some metastatic disease because he was sent to me from somebody else who had already diagnosed him.
But the interesting thing with even metastatic testicular cancer, is a lot of that is treatable as well.
Yeah, he's going to do fine in the long run.
Yeah, but young men need to know. Testicular cancer is one of the more common cancers diagnosed in young men.
And they need to self-examine.
Yeah.
Which I guarantee they're not doing.
Well, who's teaching young men how to self-examine themselves?
Nobody.
Whose role is that? Is it the dad's role? Is it the pediatrician's? Like, does a pediatrician actually teach a young man how to examine his own testicles?
No, I don't think so.
Are the dads doing that?
I don't think anybody's telling them. It's bad. There's not information out there for young men in how to optimize their health.
Yeah. All right. Well, I guess while we're on the topic of this discussion, how would you counsel a young man to examine his own testicle?
I would tell him once a month in the shower, reach down, any lumps or bumps, go to the doctors.
Yeah.
Very easy.
Yeah. And to know your own body, because oftentimes there can be lumps in the scrotal sac, which oftentimes could be on like that back part of the testicle.
Or
called
they
the
can be
epididymis.
cysts.
Right, which are cysts or fluid-filled things that are not cancer.
Right.
But if you don't know what your normal baseline anatomy feels like, you don't know when there's a change.
Right.
So I think it is really important. I think we assume that someone is having this discussion with young men how to examine themselves. And when we assume that everyone is having the discussion, oftentimes no one is having the discussion.
So do they have health classes in school anymore?
Honestly, I think it's greatly changed. And I don't know if like the PE teacher's job is to help young men understand how to examine their testicles.
Because
who was teaching sex ed anyway?
When I was in school, we had health. It was called health.
Yeah.
And you would go and they would talk about things related to your health. I don't think they have that anymore.
But the thing is, it's so awkward. Because they had that discussion in 5th grade, and they're talking about BO and vaginal discharge, and you don't want to look anywhere, and it's with, everyone in the classroom. It's not like separated at all.
Everybody's giggling.
Yeah, or giggling or just like super red and embarrassed. So are we actually hearing what we're learning?
Yeah.
And the reality is when it comes to sex education or just anatomy education, let's just take the sex out of it. We should have anatomy education, right? That needs to happen at all different times of our lives. It doesn't end in 5th grade.
But I would predict that young girls are taken to the gynecologist by their moms when they're getting around time to either have periods or sexually active.
Yeah.
And they're given anatomy, right? They should. Well, they should.
Well, yeah, we should. I remember when I was in high school, my mom said...
Here we go. We're going to get a personal story.
Isn't that the point of this podcast?
What did your mom say?
What did my mom say? So my mom said, Amy, it's time to see a gynecologist. And I remember from the moment my mom said, we're scheduling an appointment to see the gynecologist, I was dreading that visit because you just don't know what's going to happen during the visit. You just imagine getting undressed and your legs are open and whatever. You already feel awkward as a woman anyway in your body. But I don't even remember the exam at all. The only thing I remember from that visit is she took me into her office, and I remember it was like wood furniture everywhere. It was a nice office. I think there were probably like some pictures of her and her family behind her, and we just spoke. And that's all I remember. And that was so impactful because I think...
Was it helpful?
Well,
remember?
It was helpful in that it didn't make me scared of seeing a gynecologist. It was helpful in that I don't even remember feeling embarrassed, and I wasn't traumatized.
Did you leave on the pill?
Did I leave on the pill? No, I did not leave on the pill. But what I think is really important, especially when we're getting young people, really anyone in our offices, is it's helpful for us to talk to them when their clothes are on. And I know you haven't been in this scenario, but I've been in this other scenario where like you go to see a gynecologist and what do? They say the first thing when you walk into the room, go ahead and get undressed, put this gown on, make sure it's open in the front.
Oh.
And then you're like sitting down and it's like open in the front and they're like doing the breast exam. They have you up in stirrups and as your legs are open, they're talking to you. That's not a time to talk to me, right? When my legs are open towards the door, there's no curtain. I know, like, probably no one's going to walk in, but what if someone does walk in? But too often, I think we put people in those scenarios.
But just think about it. This is a bad experience for you as a teenager, but at least you had an experience. A guy has no experience. No one's going to talk to him.
Right. And that's the problem, right? Is like, at least as a woman, I got plugged in.
Right.
But no one's talking to these young men about testicular cancer and the fact that, like, hey, if you feel something abnormal, come on in. This is what we're going to do.
Who's talking to them about safe sex?
I mean, that's a problem. I don't know. I don't know.
We need to have somebody on.
We do need to have someone
and
on.
talk about this whole thing, because I don't understand, since I'm so far removed now, what's going on out there.
Yeah. Well, the interesting concept, too, you asked, who's talking to young men about safe sex? But I think the problem with that discussion, too, is oftentimes we're telling people how not to have children. And who's telling people how to have children? And you see this all the time. No one's counseling men on how to optimize their lifestyle to have children, or how to time their intercourse to have children.
I think we're talking about two different populations.
Absolutely. Yeah.
You know, one is the young man, 20s, 30s, and then you have the teenagers who are going out and having sex.
Right.
Let's face it.
Well, the problem is no one's talking, but people are still doing.
I know. Social media. TikTok.
All right, well, we'll have to get someone on to talk some sex education here.
Okay. So what have you seen this week? Anything fascinating, funny?
Fascinating or funny? Let me look through my case files here. All right, I got something.
Right.
This wasn't this past week. This was maybe like a couple months ago. So I have a gentleman who's in his 50s, and I put a penile implant in. Happy patient, right? Always good to have. And now that his surgery is over and he's fully recovered, he asks if I want to go out for lunch.
Oh, come on. Seriously?
Yeah. How do you think I should respond? And I already responded, but I'm just curious. I'd love to get your take on this.
Mr. Smith, I'm so happy you're doing well, but I want to keep this as a patient-doctor relationship. Yeah. Now you're going to tell me you went out, you're engaged. You're engaged.
No, look, there's definitely a very fine line here. We want all of our patients to be happy and we want them to be successful and go out on dates, but that's not something I can do as a provider.
So what did you say?
Well, I said, look, I'm your doctor, and I know yes, you've recovered from your surgery and I no longer need to do surgery on you, but you are still my patient, So yeah, I had to tell him no, but it was so funny. It reminded me of this time when I was at University of Iowa and I had a gentleman that I put an implant in. He was probably in his 70s. And he was like, Amy, I'd love to know who you are outside of the office. And I'm like, here I am. This is what you got. And he's like, I'd love to take you out for lunch. And I'm like, no, you're still my patient. He's like, no, but you did surgery on me. We're all done.
I know, but there's kind of a pattern here.
No, this is not a me problem.
The implant problem. The patient gets an implant and then he wants to go out. I don't know, Amy. I'm a little concerned.
Yeah, he was like, well, you did my surgery. I don't need to be your patient anymore. And I said, I'll see you back in 3 months, sir.
Terrible.
All right, so why don't we get into some breaking bedside news?
Okay, so there is an interesting article that you and I shared in the Journal of Sex Med concerning spontaneous erectile function recovery among young men with ED taking tadalafil, 5 milligrams Cialis, daily.
I love this study, Larry.
You like this study?
Yeah.
Tell me why.
Tell me why. Okay, let me tell you why I like this study. So first of all, it enrolled young men. So they define young men as less than 50. I think that's reasonable, right? With identifiable psychogenic ED, right? So we oftentimes in our clinics, we try to define if someone has organic erectile dysfunction or psychogenic. And then if they have psychogenic, we say, send them to a sex therapist. But we have a role in the patients who have psychogenic ED. And this study is looking at young men with psychogenic ED and putting them on Cialis or the tadalafil, and looking at their erectile recovery even after stopping the medication, and their erectile function improves even after stopping.
Right.
So we're treating what we would historically think to be a mental, right, or a something in the mind, which, by the way, I hate that terminology. I would never tell a guy that his sexual dysfunction is in his head, right? But I tell him it might be in your brain, right? And with any sort of reaction, if someone is happy, excited, sad, frustrated, stressed about something completely unrelated, that signals a cascade of neurotransmitters, right? And chemicals that will physically determine the functioning and the blood flow to the penis, right? And so I think when people understand that, literally the only way to disconnect the brain from the body, right, is to physically disconnect those two parts of the body, which we cannot do, right? So I love, and this reinforces what I was already doing in my clinic, which is treating guys with Cialis who I know don't have a physical problem and seeing them recover.
Right, and I think it just reinforces to them that they don't have a serious problem.
Yeah.
And it gives them good self-image, and then they can come off it.
Yeah.
I wonder how many don't come off.
It's interesting because I think in young men who see me, who are coming in with sexual health concerns, sometimes their concern is, Amy, I'm worried I'm going to become psychologically dependent on Cialis, and I totally get that idea. But what I do tell guys, and I am citing this study, is that if you want to come off this medication at any point in time, you can, and you'll probably still maintain your erectile recovery, right? But what I also tell guys is if you like the medication, like many of my patients do, and you want to stay on it, that's fine too.
Yeah, we talked before about the fact that this medication is being used by a lot of people who exercise to just increase vascular flow to their muscles.
Yeah.
So, these young guys may just stay on it anyway.
Yeah. Now, I think it goes to this concept of like, are we overprescribing, right? And with all these online pharmacies, there are some people that have a problem with young people being started on these medications so early on. The way that I look at it, and I love to get my patients off medications, but when I come across a medication like daily Cialis, I am very pro daily Cialis. I look at it, even though it is an FDA approved medication, right? And it's undergone a lot of studies, I kind of look at it as more of a supplement in that mind frame of like, look, it just helps with blood flow.
And not only that, as a physician, I would rather be managing it than having them buy it online.
Yeah.
I mean, I just think there's dangers there.
Yeah. So I think it's really important for young men who have concerns regarding their erections is to see someone, because even something like a low dose daily Cialis, you put them on it for a few months, that might just do the trick.
Yeah, I agree. I thought it was a good study.
Yeah.
Thumbs up, thumbs down.
Oh, 2 thumbs up for sure.
All right.
Welcome to today's episode. I am thrilled to introduce a remarkable guest today, Dr. Jonathan Clavell.
Dr. Clavell is a board-certified urologist and men's sexual health specialist based in Houston, Texas, and founder of the Vitality Urology Institute. He completed his medical degree at the University of Puerto Rico Medical Sciences campus and went on to complete his urology residency and a fellowship in sexual medicine and prosthetic urology at the University of Texas McGovern Medical School and MD Anderson Cancer Center. He is recognized as one of the highest volume penile implant surgeons in the United States.
Jonathan, it's so good to see you today.
Good to see you too.
Thanks so much for coming in. Always good to see you. I always see you at the scientific meetings, and I'm glad I'm in Houston because then we get to reconnect in person.
Absolutely. No, I'm a little bit starstruck and also honored to be here, and I'm excited for our conversation today.
So I know you very well, but our audience doesn't know you that well.
I know him well,
You
too.
know him well.
I'm over here, remember?
So you're a specialist in men's health, and a lot of your content talks about you and other urologists as being the gatekeepers of men's health. I'd love for you to delve into that concept.
Absolutely. Everything started back in residency. I always wanted to be a urologist once I started medical school. Actually, no, it was midway through medical school. After my third year, I wanted to become a urologist.
I'd say it's pretty rare for someone to start medical school wanting to be a urologist. I have concerns about those people.
That would make me weird, a weird guy.
Excuse me, but I started medical school wanting to be a urologist because I had worked in college in the summer for urologists.
Okay,
so it was the only thing I knew.
All right, fine.
No, for me, I didn't know anything about urology until I did a rotation, and I really enjoyed it. But when I went into urology, I thought I wanted to do oncology. And it wasn't until I was invited to be part of the SUPS meeting, which the prosthetic urologists, they do a residence course at the SMSNA meeting, and they invited me, and I remember sitting there looking at all these guys talking, and gals talking about the sexual medicine and prosthetics and all that. I'm like, you know what? I see myself doing this. And that's when I decided to pursue this type of career. Run Wong, my mentor, he was the one who opened the doors for me to create a fellowship. He said that I've always wanted to have a fellowship. You want to be a fellow? Yes. Okay, well, here's all the paperwork that you have to fill out for us to create a fellowship. So
you were his first fellow.
I was his first fellow. And the rest is history after that. I'm very passionate about the topic. Men come in, you both see this all the time, like men come in very vulnerable, and we can really transform their lives. And it's very rewarding.
Yeah. And getting back to this concept of us being gatekeepers, whose role is it in medicine to take care of men?
I mean, I'm biased.
Yeah.
I might say it's urologist.
Yeah.
But I say it's every healthcare.
Yeah.
You know, everybody in healthcare. Not even, it doesn't necessarily even have to be a physician. It could be a psychologist. I mean, as soon as you hear somebody having relationship problems, like, let's start asking them questions, and you can really, when you start digging into it, you'll find many things that can improve. And sometimes me as a urologist I don't have the tools to help them.
But I don't know whether you've noticed this, but what I've noticed is that if I see a young guy for something related to, of course, urology, I become his doctor.
Yeah.
Absolutely.
Because they don't have doctors.
Well,
because they don't go to gynecologists
Right.
like women do
Right.
when they start, having periods. So it's very different dynamics with men.
And that's why, specifically, with me, and for you guys as well. I mean, I feel like I'm preaching not to the choir. I'm preaching in front of the Archbishop. So yeah, I mean, whenever somebody comes in for low T, I mean, that's one of the first things that now we're seeing, at least for me, for the past 5 years, whenever they come in for low T and they start telling you all these other issues, like, hey, you should see your primary care doctor. Hey, you're above 45 years old. Hey, let's actually get a colonoscopy. And you actually can start educating them about their health. And I know there's this big misconception that men don't care about their health. We do care about our health. It's just like sometimes we just don't want to talk about it, but we do care.
Yeah. So let me ask you this, and I want to ask this, take your healthcare provider hat off. Like, you as a young man, what are some of those barriers for you seeking help? Why don't you want to talk about it? Like, I see it from an outsider's perspective is that there are no healthcare specialists that are mandated to learn about your health as a man. So oftentimes men come in to see their primary care doctors. They ask very basic men's health questions. Can you check my testosterone? They were never taught how to answer those questions. And so they don't give a good response. The person says, why am I going to go back? I'm not getting the help. And then we say 10 years later, why didn't you see us sooner?
I believe is that our healthcare system is broken. We know that. And unfortunately, we don't want to spend more than 5 minutes with a patient. And whenever we mention the word erection, now, there's a 10, 15-minute conversation. And most providers, they don't want to have that conversation.
Yeah.
So yeah, I mean, usually when they come into their primary care health doctor, what they do is they talk about their blood pressure, they talk about if they have diabetes, all your labs are normal, off you go. And they really don't dive into the nitty gritty and the concerns that I might have as a man, right?
Yeah.
Specifically, I mean, right now, for example, I'm 40 years old. We all know the statistics, right? Like 40% of men above 40 years old have some degree of erectile dysfunction. And
Are you sharing something with us today?
I might be. You can talk to my wife afterwards, and she can give you some insight. We can have her in the couch next time you're sitting beside me. So I know those statistics, and I know it might be coming eventually, right? But fortunately for me, now putting my healthcare hat on, I know that there's hope. I know that there are options, but most men don't know that there are options. We believe that, it's just a part of health. It's part of aging, and we don't talk about it.
So do you think social media has helped?
Absolutely.
You think it's helped?
Yeah, I mean, at least, even if there's a misconception, at least put the topic out there, put the message out there, and now I can start asking questions, and I can go to my primary care doctor, I can go into my urologist or whoever you're seeing to talk about it. And then we can always demystify any myths that are out there.
Let's talk a little bit about your background. So you grew up in Puerto Rico. You did some of your training in Puerto Rico. What do you think some of those cultural differences are in terms of men coming in seeking ED care?
Well, in Puerto Rico, it's like, I believe there's something in the Caribbean waters, and we tend to be a bit more open about sex, right? So
what do you think is in the water?
I don't know. You tell me. You're in Miami. You tell me. You see that all the time as well. But yeah, I mean, we tend to be a bit more open about these topics. But culturally speaking, and I came in from a very religious family, and we didn't talk anything about sex, right? But culturally speaking, it wasn't such a big impact, and specifically for me. Once you get exposed to something, you start getting desensitized, and now you feel more comfortable talking about these topics. So, yeah, I mean, I believe if it's not this, if I have a patient coming with erectile dysfunction and they are from Puerto Rico or Colombia or Venezuela, again, all the countries that are around those Caribbean waters, is a very different conversation if I have a guy who's coming in from Arkansas, right? Or at least not necessarily a different conversation, but just a different approach. But at the end of the day, if they're coming in for erectile dysfunction, I tell people, I'm just talking to a man who has issues and I know I can help them.
Yeah. You know, when I first started in Miami, I was worried that none of the guys, you know, were going to want to see me just because of the cultural differences in Miami and the difference in the population. And that hasn't really been the case, you know? I mean, I think for a lot of men, once you give them the microphone and you create a safe environment, they don't stop talking. And they need more than those 5 minutes.
You know, I've noticed in Houston, though, having female fellows now and residents, a lot of the men don't want to be examined by the women. I mean, they'll talk to them. But when it comes time for a genital exam, they'll actually say, could I see a male doctor? I don't think it's that unusual here now.
Does that happen to you?
Well, so I think the difference is when the guys are coming in, they're expecting to see Larry Lipshultz, the man, right? And so when a woman walks into the room, they have to completely change how they're processing this visit. So it was very different when I was in training at Penn. Most of my faculty attendings were men. So I just knew that the first 5 minutes I walked into a room, I had to set the scene. I had to build rapport. And that was like, all right, I'm up for the challenge. In my current practice, my name is Amy. I have never met a man whose name is Amy, you know? And so
soon you will.
Soon I will. And so people know they already are preparing to see a woman. And so, but it's self-selection, right? I'm seeing the people who don't mind seeing a woman, but it's much easier as a woman in urology or in men's health when you're out in your own practice and people already have that.
No, they already know they're going to come see you.
So. Exactly. So let's get into the discussion of erectile dysfunction. And there are so many options these days, and we haven't yet on this podcast laid the groundwork for all the different options. So let's say a middle-aged guy comes in to see you. He's never tried anything before. Where are you starting in terms of your evaluation and treatment?
So first of all, having them understand that they're not alone. I mean, that they're not the only ones. And I literally just bring them the statistics. Like most of the time, whenever they come in with these issues, I mean, if they sometimes come in before 40 years old, but just understands like, hey, you're not the only one going through this.
And by the way, when I say like middle age, I'm talking about the guy like in his late 30s, because that's middle age.
No, it's not middle age.
No, it is middle age. Look, the average the average life expectancy is 77 years old. And therefore, like 38, 40 is middle age.
Now I'm becoming depressed.
I know. You're such a Debbie Downer.
So sorry, continue.
So usually what I try to do is first educate them about, there are different, what I call the categories of erectile dysfunction, and not everybody falls in the same one, and sometimes they can be intertwined. So when I tell them there's 4 categories, there's the vasculogenic, right? The vascular erectile dysfunction, which is a more common one that we see. Men who have problems with their hearts, problems with diabetes, high blood pressure, smoking, all these things that affect blood flow getting into the penis. There's a hormonal one. Which again, Dr. Lipshultz can talk about this 10 times better than I do. But again, testosterone, thyroid, I mean, there are hormones that can also affect our erections. And then there's also the what I call the neurological ones. And that's usually when the nerves are not able to innervate the blood vessels that bring in blood flow into the penis. That's usually people who have spinal cord injury, men who have their prostates removed after a cancer. That's the type of ED that they see. And the one that nobody talks about, which is a psychological one or psychogenic. And I usually tell people, it's like, it doesn't mean that you're crazy. It doesn't mean that you're necessarily depressed. It's that you are thinking about the wrong things and during the act of sex. And what I try to remind them is, us men, we are fools. And every single guy who has the first time that they're not able to get an erection or they lose it midway, what happens is the next 10 times, all you're thinking is like, oh crap, will it happen again? And then this becomes this, snowball effect in which you can get into a dark room where the walls are kind of like closing up on you and everything gets dark and you feel that you're alone, right? So I try to remind them, you're not alone. There are options. If it's purely psychogenic, sometimes I am not the best person to help you. Let's talk to a sex therapist so we can try to start focusing on the pleasure, try focusing on your partner and not necessarily on your penis. I tell them your penis is not LeBron James, it's not Lionel Messi. You don't have to be like cheering him on when you're about to have sex. And once they understand those things, then
now I have that picture in my mind.
And then once they understand those things, now we can start talking about treatment options.
The one thing that we hear so often is the man saying, I couldn't perform. And I think that's whole concept of that. We talked about that, about the man having to perform. The woman doesn't have to.
Oh, we have
and that's pressure.
Yeah, I mean, we have the difficult part, right, or the hurdle that we have as men is like we have something that's visual that gets bigger, it grows.
Or doesn't.
Or doesn't, exactly. So when it's something that's visual, it becomes sometimes also a relationship problem, because the first thing that the partner now starts thinking is like, oh, he's not attracted to me anymore. And then this becomes this issue. It's like, no, it's not you. I'm not sure what's going on. And again, it increases stress, and something that could probably start as vascular, now you're also adding the psychogenic component. So we just have to try to find ways to help them regain their confidence and also regain their erection.
Yeah. So let me ask you this. Again, we're going to take your healthcare provider hat off.
You're asking something personal.
I would ask both of you as men.
She never stops.
Do you feel like as men who also specialize in men's health, when it comes to like your own bodies and your own relationships with yourselves and with others, do you sometimes know too much, or does your profession impact any of your personal sense of self?
I'll be really honest with you.
Yeah.
Yes. I mean, it definitely, in my case, it helps. Because again, sometimes you might have, my wife will kill me for this, but sometimes, I mean, you might not be able to perform like you are used to. And I'm here thinking, well, I had a really long day. I'm just thinking about something else. I have a meeting coming up or a presentation I have to do, whatever. And I know that it's okay.
You give yourself some grace.
I 100% agree, because I think knowing all the categories and knowing you're not in them, I mean, and this will pass.
Exactly.
You understand that. And I think that's the advantage you have as a medical professional.
So I try not to create the snowball effect and the next 10 times thinking, oh, will it happen again? Because I know the next time I'll be fine.
Right.
Yeah. So I think you're not catastrophizing.
Exactly.
You're understanding that
what were you going to say? She's now going to give a very intimate, personal experience.
No, I think for me, just in terms of like my own body, is I know that like, hey, if it doesn't happen or I don't orgasm in a certain scenario, okay, that happened one time. It doesn't mean that's going to happen every other time. There's so many factors that play a role.
But do women worry like guys worry if it happens one time? I mean, isn't it more situational with women than it is with men?
That's a good question. I think it's situational for men and women. I don't know that there's much of a difference there. I think like for me, I would say it is so variable. I think we think that guys, if they climax, it's like they climax the same way every time. It always feels amazing. There is no variability. And you'll have to tell me if this is like true or false. I would say like for women, it is so variable. And there are so many factors that play into that variability. And because I know a lot of these factors, I give myself grace.
I don't think it's that variable in guys.
I mean, there is less variability, but but it could be variable. I mean, especially we're talking into the nitty gritty now, talking about orgasms and ejaculation, for example. And there's the pelvic floor that plays into effect. And I mean, let
me tell you something. Guys do not think about the quality of their orgasm as much as women do.
Oh, true.
I mean, women, that's like their thing. They talk about it. They write books about it. They have, The View. You go on The View and talk about your orgasms. But I mean, guys don't share that much either about that.
But I think part of that is because we don't have any treatments that are FDA approved for guys with orgasmic dysfunction. And I would say those are some of my most distressed patients are guys who can't climax or have a muted orgasm.
Yeah, but that's different than qualitative. I mean, that's like yes or no.
Yeah.
It's binary, Some guys that's terrible. So difficult to treat.
Very difficult to treat. Yeah. Well, thank you for allowing me to digress with that conversation.
And she apologizes to your wife on the air.
Okay, so in terms of treatment options, like, are you going to, from the get-go, start pretty much all these guys on, like, tadalafil or sildenafil?
Absolutely. Yeah. I believe tadalafil is any guy who has even mild erectile dysfunction, I truly believe that they should be on a low dose tadalafil daily or every other day. I tell if it's a really young guy and they're having side effects from it, I tell them you just cut the pill in half.
Yeah.
And sometimes it could just be what I call the Bugs Bunny juice, and which is from the movie Space Jam with Michael Jordan and Bugs Bunny. The Looney Tunes, they feel like they're not playing well, and they give this Michael Jordan juice so they can play better, perform better. Sometimes for these guys who have psychogenic ED, I give them a low dose tadalafil, and sometimes that gives them their mojo back.
You call it Bugs Bunny juice?
I tell them this could be just a Bugs Bunny juice.
I love it.
But it could also, it can create, we already know that it can create hypertrophy of the smooth muscle inside the penis. So it's something that can also help them. And sometimes it could be just regaining their morning erections.
Yeah.
And then they get that morning erection now, or they wake up in the middle of the night with an erection. They're like, man, I'm back. And now
Let me
your
ask you
stress
something.
level starts
You
decreasing.
mentioned it. How significant do you think it is when a man loses morning erections? Because to me, it's way blown out of proportion.
True. I mean, sometimes there are some guys that show up to my office and they tell me, "Oh, doc, I started losing my morning erections." I'm like, well, I mean, it doesn't happen all the time. It's not like you're sleeping the entire night with an erection, right?
I know.
So yeah, we already know we get 3 to 5. If you happen to wake up in that gap,
Right.
in which you didn't have a morning erection, doesn't mean that your erections are now starting to wane for the rest of your life.
Yeah.
So I try to remind them that, hey, it's not always, but sometimes I tell them, just monitor yourself, be conscious about these things. And sometimes when you wake up in the middle of the night to go to urinate and you can feel it down there, okay, I'm good. I think everything's going to be working well. But going back to your question, I start them on at least that daily tadalafil. And sometimes I boost it up with either a higher dose of tadalafil or a Viagra. And that's what we start with. I educate them on how to take the medication. I believe that most men who fail medications initially is that they're just not taking it correctly.
Yep.
They take it 10 minutes before sex, and I tell them, man, you cannot do that.
I think the biggest problem is the Viagra because they're not told to take it on an empty stomach.
Absolutely.
Yeah.
Absolutely.
And that's key, especially on primary care.
Yeah. So for the viewers, why do you prefer tadalafil over Viagra?
I mean, it's longer acting. The half-life of the medication is 18 hours. So I tell men, it's like, hey, that medication is going to be running in your veins at 100% for at least 18 hours. They call it the weekend drug. You take it at Friday night and you're good until Monday, right? Because that medication lasts in the system a lot longer. Because many guys ask me, well, doc, why don't you give me the Viagra? And Viagra has better marketing, right? So doc, why don't you give me Viagra every day? It's like, well, Viagra, you have to take it 2 or 3 times a day. So I tell them to take the Cialis. If they're taking the full dose Cialis and they want to perform, I tell them you can take that thing in the morning. Take it at lunch. Take it several hours before sex in order for it to work. You don't have to worry about what you eat with that one. With Viagra, just like Dr. Lipshultz, you have to take it right. You have to take it at least 1 hour before sex with an empty stomach. Most of the time, many men are having sex after dinner.
How do people do that, though? I still have yet to understand how people eat a full dinner and then have sex.
No, wait.
That'll be
But
another
what I tell my patients is to take, if they want to, take the Viagra a half an hour before dinner.
Absolutely.
It goes into an empty stomach. It gets absorbed. They're good for the next 6 hours.
And you don't have to be thinking about it. So I tell them now, whenever you're going to perform, that medication is already running in your veins. You're not thinking, oh crap, I have to go get the medication. And usually that's the biggest thing. And whenever these guys come in, that they come see you after seeing their primary care doctor, or they buy them online, because online, most of the time they just buy them. Nobody tells them these little details. And then you're like, okay, let's actually start this before we go into more invasive options.
What do you think about online? What do you think about buying the stuff online? No doctor, just buy it.
I mean, I have mixed feelings about it. I personally don't endorse it, mostly because, again, they don't know what they're getting.
Right.
And the other thing is they're more expensive, right? I mean, what they start doing is they start combining these medications.
Which makes no difference.
No difference, exactly.
Or they could just combine it and pay way less.
Exactly. So I always combine them.
Yeah.
And I'm telling them, okay, instead of you getting the whatever, I'm not going to say brands, but instead of you buying the one from this company that comes in a really special package, you can go here to a local grocery store, an H-E-B or Kroger or whatever. You can get these medications for $30. You get a 90-day supply for $30.
I know, unbelievable. But now they're pushing apomorphine.
Yeah.
You've got to take enough apomorphine to get nauseated for it to do anything.
Well, that's the thing. I haven't found huge benefit, but maybe we're seeing the select group of people that don't benefit from taking these medications. Maybe there are a lot of people that benefit
from apomorphine?
I
don't think so.
Yeah. I don't know.
What do you think?
I think it's.
I mean, I'm not a big fan of apomorphine. Same thing. I haven't seen many men who really benefit from it. There are other medications that can help boost their sex drive, and sometimes that indirectly can help with their erections. But again, not necessarily giving them a stronger erection, but by increasing sex drive, you want it more. Sometimes now you're getting your head out of it, and sometimes you can actually have a better erection.
Yeah. So let's talk about combining medications because you mentioned that. And I used to be very strict with patients, in terms of the Viagra and Cialis. I'm like, if you take the Cialis and you want to try Viagra, wait at least like 2 days before you take Viagra. Now I don't worry about any of that stuff. And some people get a little bit worried about combining these medications, but I offer that to my patients. What do you find the benefit in terms of combining, let's say, a daily Cialis with an on-demand Viagra? Why would you use 2 different ones?
I mean, you can use the same one sometimes. I mean, sometimes I have guys, it's all about timing and preference and sometimes side effect profile.
Yeah.
There are some guys that can have some side effects with the Viagra. There are some guys that don't have side effects with, that have side effects with the tadalafil. So I tell them, sometimes what I do is I give them both. Actually, 3 medications. You have the 5 milligram, or the daily tadalafil. You get the full dose tadalafil. You get the full dose Viagra, and you start playing with these at home. I have a little handout in my office that explains to them what are the side effects to be looking for. Like if they have reflux with the Cialis, or they have muscle aches with the Cialis, I tell them, let's try the Viagra. And you can sometimes, if you found that it was really strong erection, cut it in half, and now you have 180 supply, with these medications. So it's all about patient tolerance, patient preference, and whatever works for
Patient
them.
education.
Absolutely.
Yeah, I like sometimes combining the two because then they get the long-lasting effects of the tadalafil, but the quicker onset of action of Viagra. There's actually a newer medication that's going to be, released like in 2026 that is essentially an intranasal Levitra with an onset of action of like 10 minutes. So I'm pretty excited for that.
It is, but Levitra, is not as strong as Viagra. So I don't know.
Yeah.
I don't know the target audience. I haven't heard much about this.
Yeah. Well, stay tuned, Larry.
I will.
Keep you posted.
Yeah. Invite me
We
for
have an
that.
inside person here.
It's the first time I ever heard about this.
All right, so we spoke about the pills. What else are you talking to patients about when it comes to ED therapies?
Whenever a guy comes in with erectile dysfunction, I am one that I tell them all the different things that we have. I tell
like
them,
upfront, from the get-go.
Upfront. I tell them there's oral medications, there's a vacuum erection device with constriction rings, there's injection therapy, there's intraurethral therapies, which I'm not a big fan of. There's low intensity shockwave therapy, there's penile implants. I tell them, you stick with me, I can get you an erection one way or the other. And that way they understand, it's like, okay, this doctor has my back. And I know that one way is going to be trial and error maybe. But there is always something that we can offer you if you need it.
Now, you do a ton of penile implant surgery. So who are the guys that end up making their way to getting that surgery?
I mean, with my online presence, I do get a lot of guys like that. They are already ready for it, which is very different than the guy who comes in, I'm asking for options. So many men nowadays, they actually show up, Doc, I'm ready. I already did
Let
all
me
my
ask
research.
you something. So if a man shows up and says, Doc, I'm ready, but he hasn't tried anything,
I would not offer it.
What? You would not offer?
I would not offer the implant. No, I mean, I don't.
Oh, I meant, yes, that's what I meant. So you don't just say, hey, great, I'll do it.
Absolutely. Many people, given that I do a lot of penile implants, many people think that I'm kind of like pushing implants on everybody. And I find myself actually telling a patient, like, hold your horses.
Because it's dangerous just to jump. I think it's dangerous
It depends.
to jump. Well, if they're a spinal
haven't
cord
tried
If
it.
they
patient.
haven't
oral
tried anything else,
medication,
And I
That's
tell
what I
them,
mean.
what I tell them is, it is not the first resort, but it's not the last resort either. I tell them you have to try at least a medication before we're able to consider something like that. And I tell them it's not only trying a medication once, because sometimes they tell me, oh, doc, I had one episode in which I wasn't able to perform. I bought these pills online, again, no education. I tried them, they didn't work. I cannot live my life like this. I want an implant. I saw your YouTube videos. I want an implant. I'm like, okay, let's actually talk about how do you take the medication?
Yeah.
And once you start educating them, I tell them, hey, try them again. We'll just touch base again in 6 weeks to 3 months. And then if you're still like dead set on it, let's see how everything goes.
Yeah.
How about, where does duplex ultrasound fit into your diagnostic regimen?
That's a really good question. And I don't get duplex ultrasounds on everybody, but for the right patient, like for example, somebody who I believe they might have more of a psychogenic component, contributing to their erectile dysfunction, I think it's sometimes good for them to see, okay, you had a really good response, your blood flow, everything, the blood flow is going in very well, you're able to keep the blood trapped inside without any problems. Man, your erection is fine. Like organically in your penis, your penis is fine. So I don't do it for everybody. Sometimes if I have a guy who has scar tissue, Pearlman's disease, so whenever I examine them, I feel like there's something off, I would offer it.
So given that you don't offer it to everybody, how often are you in the operating room, induce an erection, go to put it in, and they've got to bend?
Often. A straight, and we're talking now something that we can have a conversation for 2 hours talking about, curvatures. But it is rare to have a straight like an arrow penis. Like having a curvature is not always abnormal.
Right.
It is very common. So everybody who's listening to this, like it's
congenital penile
exactly.
curvature.
It could be congenital penile curvature. So again, given that I do examine them, and I consider myself like I know penises very well, and I can pull on a penis and I know where it's going to curve.
That's going to show up on the teaser reel.
So I examine them initially, but if I have a guy, for example, who's coming from out of town, then I always prepare for the worst. Because sometimes for those guys who are flying in, I'm not examining them before their surgery, so I just prepare for...
What I've noticed, though, is some of these men have not had a good erection
for a long time.
So long that when we induce one, there's a curve. So you can't have the conversation about how to treat it up front unless you've done a duplex and know that he has it.
So I do have a really good list of questions that I ask all my patients, that it literally takes me like 3 minutes for me to ask them. Like I ask them, okay, when did you start having erectile dysfunction? What is the strength of your, like how rigid does it get from 1 to 10? I know we have the 1 to 4 scale, whatever. For me, that's crap. We are with everything ever since we're like 5-year-olds. We know from 1 to 10, you can give us a number. And then I ask them, okay, are you able to, how's your duration? Are you able to keep that erection? I ask them, when was the last time you had intercourse? Again, usually that will give you a really good idea of okay, if this guy hasn't had a good erection in 10 years, he doesn't know his penis anymore, right? I ask them relationship status. I ask them about orgasm quality. I ask them, does it take you longer? Is it too quick? Is it pleasurable? Does fluid come out? Because again, all these things are not going to be affected by the implant.
For better or worse.
Exactly, for better or worse. So I tell them, we're not going to take it away, but I want to know what your baseline is. Right. And I also ask them about failed treatments and also sex drive, libido. Are you having any issues in your relationship? Because again, I will never forget, I once had a guy, he was 30 years younger than his wife. I mean, they met when he was like really, really young. And she was like in a wheelchair. She had dementia. And he's like, yeah, it's like, she wants to have sex and I'm not getting an erection. I need an implant. I'm like, well, sir, it's like, she's more on the other side than here. It might just be something else. Yeah. And I remember telling him, like, I told him, like, what happens with masturbation? Oh, doc, with masturbation, I'm fine. I'm like, well, you don't need an implant. This is not, this is just the spark is not there anymore. You feel like you're kind of like taking care of her while you're having sex. You're not going to be able to have a good
Let me
erection.
create a scenario that we talked about.
Yeah.
The man comes in with his wife. He wants the IPP. He's decided. And she's sitting there on her phone, not interested. And you get a feeling that this isn't something she wants. How often does it happen? What do you do?
I mean, in my case, usually it doesn't happen as often. In my experience, most partners, whenever they show up, they actually are very supportive about it, and they are the ones kind of like with their little notebook and they start asking all the questions. And I definitely include them, and I try to. I mean, if I were to encounter something like that, I would ask her, like, ma'am, like, what do you think about this? Do you have any questions?
Because Amy
about
had
this?
a couple.
I did have a couple like that. Yeah.
And what happened?
Well, he kept canceling his surgery like last minute. And so when he wanted to reschedule for like the 3rd or 4th time, I said, you need to come back into the office. And so he brought his wife into that visit, and she was completely disinterested, in that conversation. And so I asked her, I said, can you tell me more about what's going through your mind right now? And she said, look, he's got a lot of health conditions. And like, I don't want him to get the implant, and I'm just not that interested. And he was like, oh, but once I get the implant, you'll become interested. And I was like, I had to put my like therapy hat on. And I was like, sir, like, that's not the way this works. And I realized in that moment, as well as some other moments, that I have the potential, if I put an implant in or just put someone on testosterone and give him Cialis, we have the potential to do great good or great harm. If the partner is not willing. And then you're like, especially with an implant, now this guy can get an erection whenever he wants. There's no pop-up valve. He can keep it up for however long. And now there are some concerns that I have with that, because some men just don't get it.
So what I do in those situations is most of the time, most men that are getting penile implants, or at least needing penile implants, they are, if they're in a heterosexual relationship with a female partner, most of the time they're either perimenopausal or they're menopausal, right? So I try to ask them, okay, what are you doing for your health? And I ask them about hormonal therapy for them. And I don't go into detail, because now I'll have 2 patients instead of 1. But I do try to, same thing, educate them. And sometimes for me as a man, they already know that when a female partner comes into with my male patient to the office, they already know, like, I know, like, this doctor wants to help him. So whatever he wants to tell me, I'm not going to listen that much. So what I do is I have like a little pad, and I start writing like Peter Attia, the Drive podcast episode with Dr. Rachel Rubin, May 12th. And I tell them, you're going to listen to this. It's like, rather than listening, to me, listen to this doctor talking about your health as a menopause.
Do you work with somebody gynecologically who you can refer to?
So I do. I'm not a gynecologist, but I do work with an internal medicine doctor that she can prescribe these medications.
Yeah,
So
I think that really helps.
Yeah, because we don't have to do everything for everyone. We just need to know what is our exit strategy, what are the resources we can give to the partners of our patients, and who are the providers in our community who can actually treat them for the sake of their own health, not to satisfy our patients, but for their own health, their own desire, if that's important to them.
No, and I tell them, I mean, if we're talking about female health or hormonal health, it's like there's so many benefits outside of sex, right? That you can get with hormones. And same thing with men. There are so many health benefits. I have some guys, for example, that they're like, Doc, I want to stop testosterone. They're in their 70s. I'm not having sex anymore. I'm like, well, let's actually talk about the other good things about testosterone in your health that can actually help you.
Yeah. I'm glad you brought up testosterone. How does checking someone's testosterone or just the evaluation of low testosterone in a patient coming in with ED, how does that play a role? Are you checking all T levels in these guys?
I try to. Yes, I definitely try to check their testosterone levels because, again, there is that hormonal component as well. And I tell them, sometimes, and again, this is probably a bad analogy, but I tell them you can have all the right tools for you to be able to go into a dance. I tell them this is like you going into a dance party. You can have the right shoes, the right hat, the right partner. If there's no music, you're not going to dance. And I told them testosterone is usually what brings in that music to the party.
How do you evaluate those guys?
Yeah, I get teased on all of them, but I think it's so important that they understand that the benefit of testosterone is to increase their sex drive. It's not going to cure necessarily their erections.
But
it may have some impact.
Well, it helps them respond better to conservative therapies, right? If they're on Viagra Cialis.
The orals require some testosterone.
I've been able to salvage a lot of guys who you optimize their testosterone. All of a sudden, Viagra Cialis works great for them. And I think if we don't check their testosterone and treat it, we are doing them a great disservice.
Absolutely.
Yeah.
Well, it's also, as Jonathan said, later in life, I mean, if they're deficient, this is going to make them healthier.
Absolutely. So who are the guys that do well with an implant? Because you got some happy patients.
Yeah, I mean, I truly believe that beyond the pill, the implant is the best option. It's the one that gives guys the most confidence. I mean, it really doesn't fail you as long as it's working, of course. So I will tell you, like, anybody who fails oral therapy, you're a candidate. And I tell them, whenever you have erectile dysfunction, there's one door that you have to go through, which is oral therapy. That's the way I present it to them. And after that door, you have 4 or 5 different doors, and you choose whichever one you want. The important thing, though, is like there's this golden door that once you go through that golden door, there's no going back.
It locks.
It locks. As long as they understand that, and as long as they understand the risks and the benefits of this therapy, they can be your happiest patients. I tell people what I do is I improve the quality of life of my patients. If they weren't happy, I wouldn't be doing what I'm doing.
Yeah. So explain that. Explain why this golden door locks once you go through it.
So whenever we put in a penile prosthesis, what we do is there are different types. There's a malleable implant. There's the inflatable implant. The inflatable implant is a more common one that we use here in the United States. And what we're doing is the way I describe it is we're stabilizing your erection. And it's very important that they understand that because whenever the term or the medical term of this device is the inflatable penile prosthesis. And whenever we think about the word prosthesis, what we're thinking is, I'm going to have a wooden leg. They're going to chop off my leg and I'm going to have some, like this below the knee amputation. They're thinking they're cutting my penis off and now I'm going to become a bionic RoboCop penis, right? So what I tell them is, going now back to the orthopedic analogy, it's like whenever let's say like you shatter your bone, and we're not cutting your leg off and putting in a prosthetic leg. We're actually just putting like screws and stuff inside your leg. It's not going to make you run faster. It's not going to make you jump higher. It's still going to be your leg. You will still feel that you have your leg. You can still move your toes. What we're doing is we're stabilizing your erection whenever we do this. So we're not going to be affecting glans engorgement. We're not going to be affecting orgasm. We're not going to be affecting arousal. Sometimes there are some guys that feel that the penile implant will now make them desire their partners more. Not necessarily.
Yeah. And we're not going to make your leg longer.
Exactly.
But see, that's where we get into trouble, I think. And that is, and a man who hasn't had an erection for a long time, he remembers his erection before he had problems.
He idealizes his erection.
And then you put in a prosthesis and the thing is, hey, this is not as big as it used to be. Right.
So you know what I started telling my patients recently? It's probably for about the past 3 months, because I had this guy, he was in his late 70s and guy could barely walk. And he's like, Doc, I used to grab it with 2 hands.
Exactly.
And I was looking at him. I told him, sir, you tell me one cell in your body that looks the same as when you were 20 years old. one cell. And he's like, yeah, you're right. I'm like, why do we expect as men, why do we expect that our penises are not going to change? Everything else in our bodies are changing. My hands are getting more wrinkly. I'm getting wrinkles in my face. I'm, you can be like losing height. You're running slower. You're walking now with a limp. Why do we expect that our penis is going to be exactly the same for...
That's a great, I think it's a great analogy.
Yeah.
And that's usually what I started telling
And how
them.
do they respond to that?
I mean, they understand, okay, it's not going to be the same, but it doesn't mean it's going to be bad.
Okay, but how does that concept, which is down the road, compared to doing a stretch length? Does that help?
Many of my colleagues, they do a stretch length in the office. They record it. They have the
Can you
patient sign on it.
explain what that means?
So basically, it's you grabbing the head of your penis when it's flaccid. You grab the head of your penis and you pull it out as much as you possibly can. And usually that gives us a pretty good idea of how the implant will be when you're fully erect and you are not aroused. I need to emphasize that, right? Because I get many men who come into my office. They're like, Doc, I went to this other doctor and they pulled on my penis. They told me that's what you're going to get. I'm like, I don't agree with that. My penis is more than that. I'm like, okay, well, let's talk about your erection then. Your erection is not only shaft getting hard, there's the glans engorgement, there's the urethral engorgement. So I tell them this is the shape of the penis when you are not aroused and you have an implant. This is when you are aroused. So I tell them when you pump that implant in front of the mirror and your partner is nowhere to be found, you're not sexually aroused, what you're looking at is at your flaccid penis with an implant. And they need to understand that once you get aroused, now, again, the tissues around it start getting engorged a little bit more if they have good blood flow, right? Mm-hmm. The glands gets engorged, and that's when you see.
But most of these men don't have good blood flow. Is the most common reason that we do it.
So yes and no, and that's when we can even combine these. The Viagra, Cialis, or the Trimix gels with an implant because we can enhance the erection beyond the implant.
Yeah.
I'm a believer, again, we're stabilizing your erection, and there are things that we can do to enhance your full erection.
Such as?
Yeah. And that's when usually what I tell them is like, if you don't have glans engorgement, because the other things we have to remember, the blood flow that goes into the shaft is different from the blood flow that goes into the urethra and it goes into the glans or the head of the penis. So there are many men that can have arterial insufficiency that's bad enough for them to be able to get, hard, but it's good enough for at least to get the glans engorged. And I try to remind them, we're not taking that away either. I tell them, man, I'm not even going to touch your urethra while we're doing it. I place my implants without placing a catheter. Mm-hmm. So I'm not doing anything to it. And you still have erectile tissue around the implant. For example, one thing that I recently, I'm starting to get is like some guys tell me, well, Doc, like this implant inflates on its own in the mornings. I'm like, well, sir, that's morning wood. It's like, it's only in the mornings. Like what you're having is that you still have some blood flow getting around the implant. Mm-hmm. In the past, you might have had a venous leak, but you still have blood flow going in when you have a venous leak. So you can still have some blood flow, natural blood coming in whenever you get aroused.
Yeah, so you had mentioned sometimes combining therapies with an implant, and I offer that to my patients as well. I'll put plenty of guys who have an implant on medications like Viagra, Cialis to get that gland engorgement, which I found to be very helpful.
Absolutely. Yeah. And I mean, again, once you start tadalafil 5 milligrams, I believe you should die with it. Right before you die, you put that thing under my tongue. Again,
we'll
it's
remember
a great medication. Tell my wife about that, one of my daughters. It's a great medication. It helps with so many things. It helps with prostate health. It helps, with even healing. Like I try to keep my patients on that medication while they're healing, so they can we're dilating blood vessels. We're bringing with dilating those blood vessels. We're bringing blood. With blood, there's oxygen. With oxygen, there's health.
A lot of the guys now, the younger guys who go to the gym, will take a Cialis before because they get better blood flow.
I love it as a pre-workout, and it's obviously used off-label for that. But even guys who don't have erectile dysfunction, I'm like, do you want to take Cialis as a pre-workout? And a lot of those guys initially, they're like, I don't really know. And I'm like, look, I'm not a pill pusher, but I do feel very strongly about a daily Cialis for even in guys who don't have ED. And when they come back, they say, I freaking love it. And I don't know exactly why, because I'm not treating something. So I don't know if either of you can touch on that, but they just love it.
Yeah, but for the gym guys, they're getting a better pump.
They get like a Cialis pump.
Yes.
Yeah. I'm going to start taking it as actually a pre-workout.
Do you want me to write your prescription?
Yeah, I'd love for you to write me a prescription.
Man, I would self-prescribe it. I don't care. I don't need you to prescribe. I'll prescribe for myself. And going back to that implant, I mean,
Yeah.
it's a medical device that we place. We place 2 cylinders inside the penis.
Yeah.
There's a reservoir that usually goes in deep into the pelvis or underneath the abdominal muscles. And then we have a pump. And the pump stays in the scrotum, in which the guy, whenever he wants to be able to have sexual intercourse, or sex in general, right? It doesn't have to be intercourse. They just pump that thing inside the scrotum. Many guys are like, well, Doc, am I squeezing my testicles? Like, no, it's like we place it right next to it, or right next to them, if you have to. And you start, pumping that implant. And you get the erection. And most of the time, you have full control of the erection. It takes you 2 minutes, 1 minute, if that. I mean, you can do it in 30 seconds.
To pump it up.
Yeah. And that erection will stay there until you make it go down. Right. So I tell them it gives you that spontaneity. You don't have to be thinking about taking a medication before or injecting, the penis with a medication. You have full control of your erection whenever you do this.
I'm not a big fan of the turgidity of the pump. I just think the pump is tough for a lot of guys. And I don't know why after all these years.
I'll tell you a little secret.
Ooh, yes.
I'm 40 years old. And now I have a little bit of arthritis in my thumb from pumping this thing up. And I'm actually worried when it's my turn.
Oh, your implant?
When it's my turn. They'll have an automatic one by then or something. But don't you find that it's a thick pump?
Sometimes it is. I mean, there are some brands that are easier to pump up. There are some brands that are easier to get down. And that's when we can tailor things to the preference of the patient. And what I tell the patients, like going back to my analogies, I tell them whenever we put in the implant is imagine you've been riding a Rolls Royce your entire life. And for the past, 5-10 years, you've been taking that Rolls Royce to the mechanic. That's us, right? The urologist, their doctors helping them with their erections. And I tell them, now you're getting to a point that the mechanic is telling you, hey man, you need a new car. And I tell them, but unfortunately, the Rolls Royce is long gone. Like we are not going to be able to get you what you are used to. Now you can choose between a BMW and Mercedes.
All right, not bad.
It's not a bad car. It's going to be different.
Yeah.
And each of them has specific, features, and you're the one who decides which features you want to have guaranteed. Do you want guaranteed girth and rigidity? Do you want guaranteed comfort while you're flaccid? And what's more important for you? Inflation, deflation? I mean, these are the things that then they can choose. Okay, well, Doc, what's going to definitely make me happy is comfort. Well, let's go with the comfortable one.
Yeah.
And that's how I tell them, it's like, your Rolls Royce is gone. It's not going to be the same. I mean, it doesn't matter which implant you get, you're going to feel it. You're going to feel there's something in there, but it doesn't mean it's going to be a bad different. Regardless of which one you get, you're going to get used to it.
So tell us about some of the most common misconceptions that guys come in with when it comes to the penile implant.
Man, that one's tough. I had to prepare for that one. Okay, so misconceptions is that the penis is going to be bigger, or that the penis is going to be shorter. So I tell them, again, we're not taking anything away. I'll put in the biggest one that your penis will tolerate. So you come into the operating room, I will induce an erection, I will put your penis in maximal stretch, and trust me, I will not shortchange you, but I cannot put in an implant that's too big for you because it's going to get out of your penis. I mean, the implant will find its way.
And then talk about that a little bit. What are the risks of potentially oversizing an implant?
So basically what happens, I mean, and again, we're putting a very strong, sophisticated balloon inside the implant, inside the penis, and it has at the tip, but both ends, it has a harder silicone tip, right? And what happens is, I mean, I'm going to show it to the camera here. Imagine this is your penis, and now we're putting something that's like that. Eventually, that thing you're going to start pumping it up, and that thing will eventually pop out of your penis.
And it'll be uncomfortable.
It'll be
you'll feel
painful.
soreness and pain.
For example, recently I had a guy that came in, he was implanted somewhere else, and he came in with excruciating pain. And I thought he got an infection. I'm like, it's already been 3 months. Everything looked okay. And then when we went back in there thinking that he had a subclinical infection, I took the implant out, and he had an implant that was 3 centimeters longer than what he measured. So, I mean, I'm not sure how they were able to fit it. He was not able to inflate it because every time he inflated it was excruciatingly painful. So we took it out, we remeasured him, we put it in, again, 3 centimeters shorter, and the guy's happy.
Was it the rear tip or was it the whole cylinder?
I mean, he had rear tips, but he didn't have a 3 centimeter rear tip.
It wasn't just the rear tip.
Yeah. He was just oversized.
Yeah. What are some of the other misconceptions?
So that the implant will save their relationships. That's one common thing. I have many guys like, Doc, this is going to save my marriage. I'm like, well, your marriage is a little bit more complex than your sex life, right?
Have you seen instances, though, of an implant saving a marriage?
I'm not sure if it saves them, but it reignites it. I mean, for sure. I mean, sex is a big component in a marriage, in my opinion. And there are many couples that truly value their ability to be able to penetrate. Not necessarily because sex is very complex. You can do many things that doesn't involve sexual intercourse specifically, but there are partners that need that for some reason, right? And yes, I mean, the implant can transform a guy's life. The other thing is, big misconception is that the implant will only help me with my erection and that's it. I'm a true believer that this can help a guy in terms of his confidence, in terms of his, how he projects himself with his family members. I will never forget, I once had a physician who flew in from another state. And he was an ophthalmologist. He was in his 40s, married, had 2 kids. And he's like, my life is just going to work and going to bed. Like, I'm depressed, and I know it's because of my erection. And we got him the implant. He's like, he tried everything else. He wanted to come to Texas because he didn't want anybody around him to know what he was getting himself into. And I remember talking to him 3 months later, and he's like, my life is upside down. Now I want to go out with my wife, and now I want to go out with my kids and live a normal life. So this can really transform a guy's life.
I love that. So it's not even like, even if someone is not sexually active, for some people, it's just knowing they can get an erection when they want it can completely change the way he goes about his day.
Self-image.
Yeah, I love that.
Self-image.
Which we oftentimes think of that as being like a vain thing for a man, but it's not. There is nothing vain about wanting to feel good in your body.
And talking about vanity, one thing that I also want to, there's this big myth that many people think that men want to get their implants for themselves. And I get many men that I ask them, what is your goal? And they tell me, Doc, my goal is I want to be able to satisfy my wife. I want to be able to satisfy my partner. And we sometimes feel like this is just like men who are being self-absorbed and all they want is like to have an erection and that's it. And no, I mean, sometimes they are thinking about their partners, and sometimes you have like these huge guys that look like football players crying because they're not able to satisfy their partners. So it's something that is very important for everybody to understand and the partners to understand. It's like, hey, sometimes they're doing it also for you.
I just think you have to be a little bit careful when you're into that satisfying your partner situation, that she understands what's going to happen and that he understands that maybe that's not the only problem.
Absolutely.
I think it's, you worry about doing the implant and it's just a Band-Aid for a much bigger interpersonal relationship.
And that's why I tell them it's not going to necessarily save your marriage.
Right.
Whenever they come, it's like, Doc, I want to save my marriage. Like, this is not necessarily going to do that.
Yeah.
I mean, all I'm going to do is give you an erection.
Right.
Yeah.
Nothing else.
One of my favorite questions to ask men, any idea what it is?
Oh God, I have no idea. I'm scared to even go there. What?
How does your partner climax?
What does that mean?
Is it, and then I'll give examples. Is it with penovaginal intercourse? Is it with anal? Is it with oral? Is it with your fingers? Because a lot of men kind of look at me like, I think, and so, well, I would never say to a guy, well, yeah, your partner climaxes with a vibrator, so I'm not going to treat your ED, but it helps open up this conversation.
How many
of
guys
pleasure.
know where the clitoris is?
Yeah, I would say then we go to the anatomy. I take them in a separate room and we talk about the clitoral anatomy and everything that goes into it, and you see this light bulb that goes off. And I say that not to say that your penis is not important, because I've dedicated my career, like you both have, to, helping men and their penises. But I also, my goal is to maybe take some of that pressure off, that you don't have to be everything for everybody all the time. And your penis is a great tool, but maybe we can add some other tools.
I think that's a great point.
Yeah.
That's good.
Yeah. Now, and any other misconceptions, like I've seen guys when I show them the implant in the office, they're like, whoa, that's a lot of stuff that's going to go into my body. Can you touch on that?
Absolutely. I mean, it's, again, the only thing that they're really going to be interacting with is going to be that pump. So yeah, there's a lot of mechanics behind it. It's a very sophisticated device. But they have to understand, it's like, yes, that's all the mechanics and all the technology part. That's for me to worry about. Yeah. All you have to worry about is, can you get this? Can you press on this thing? Yeah. Can you press on this little button?
So let me ask you something. Are you showing them the out-of-the-body prosthesis, or are you primarily using the model to pump up and show them what happens?
So sometimes I do show them, and it all depends on who's your patient.
Exactly.
I mean, right? So there's the engineer type, or the programmer that wants to know all the details about of the device, and sometimes they come in with a little ruler and starts like measuring the tips of the implant. And I try to tell them, man, you're you're way overthinking this. And another analogy that I tell them is because whenever they start talking about all the specifics about them, I tell them, okay, sir, imagine like you're going to get a flight from Houston to Miami. And I'm telling you, I'm going to be able to get you from point A to point B, and whenever you get into that airplane, you're going into the cockpit for the pilot, and you start asking, what's that button about? What's this button about? It's like, dude, just sit down,
enjoy the ride.
Enjoy the ride. I mean, this is a
great analogies, right?
I mean, I have these conversations like 10, 15 times a day.
But I've noticed there's a lot of people who I think get scared with all the tubing. And you got to kind of feel out the patient, because you can get them, as you know, inside is like a model that you just pump up and oh my goodness, that's great.
Something that I do is I have a little album in my phone. It's in the hidden folder. I have two little girls, so they cannot, whenever they go into their phone, I don't want them to see penises. But I have this little folder in which I show them. It's like, hey, look at, these are all guys, and it's like you have a guy who has a black guy, a Hispanic guy, small penis, a really big penis, and I show them these are all guys with implants. It's like, what do you see there? Doc, I just see a bunch of penises. Exactly. So don't feel like you're going to be exactly like this guy. I mean, you're not. I remember when I was a fellow, I had this guy who showed up with the little mannequin from one of the companies in one of their pictures showing, it's like, hey, Doc, but look, in this picture, the penis is pointing at at a 30-degree angle. I'm like, sir, this is like me going into a plastic surgery room. It's like, hey, I'm going to get a facelift. Look at Brad Pitt. You're going to have to make me look like Brad Pitt. It's not going to happen like that, right?
Yeah.
So they have to understand that things are going to be different. I also remind them that they're undergoing a surgery, even though, I don't sugarcoat it. I know there are some providers and some physicians that they're like, oh, this is a small procedure in which we're going to do a small opening and we're going to do this and that. I'm like, no, man, we're going to do an incision underneath the bottom of your penis. This is a surgery. There are risks involved with that surgery. I tell them this could be the best thing you've done for your sex life. This would become your worst nightmare if something really goes wrong. Yeah. And sometimes that can also empower them to take control of their own health and actually follow the instructions. Because there are some guys that they do well, or they go online and they research Dr. Jonathan Clavell, and they go all through my reviews and everybody's doing great. And I will never forget, I had this guy that post-op day 3, I feel amazing, and he went to the gym. And he didn't only lift weights, he got into a sauna, and he sends me a picture of a bunch of swelling. I'm like, what did you do? Oh yeah, I was feeling great, so I went to the gym. I'm like, there's a reason we have instructions, right? So they need to understand that there are risks when it comes to this surgery. And as long as they understand that, usually if they follow the instructions, they're gonna be happy.
What do you quote for infection rate?
So I tell them, the research studies show about 2%, 1 to 2%, and I have a pretty good track record. I tell them my infection rate is less than 1%, and I tell them I am not immune to infections. I mean, infections can happen to anybody, and I tell them if you go to a place and they tell you I haven't had an infection in 8 years, they're probably either not operating enough or they're just flat out lying.
What are you using in the operating room?
So, well, in the operating room, depending on which device we're using, I do irrigate with Irricept.
Do you still do that?
I irrigate with Irricept, but I dip if I'm using one of the implants that has a hydrophilic coating, I do dip it in antibiotics.
Right. But otherwise, you just use Irricept. Big debate.
I know.
Huge debate. I'm going to have him.
Really
I'm going to have him on. I'm going to have Eddie on, and we'll hear about the whole thing.
So you mentioned some of these side effects. So for the viewers, other than infection, what are the other ones that you tell patients about?
I mean, there's basically 4 big things, 4 big categories that can happen for us requiring to have to do something additional to this. Number 1 is that you got an infection. It's the one that we fear the most, because whenever there is an infection, most of the time we have to do a second surgery to remove that implant, wash everything out, and depending on the health of the tissues and also the health of the patients, then we decide if we have the opportunity to be able to get another implant. There's another category, malfunction, right? This is a medical device. Even though it's a very good medical device, it can fail. If you are young and healthy enough, it will fail. So for example, whenever I have a guy who's in his 20s or in his early 30s and they're coming in wanting, doc, you have to maximize and add an additional whatever length. I'm like, sir, I'm not thinking about your erection next year, because I know you're going to be a bull. I'm thinking when you're 70, will you be able to have an erection, right? Because, for example, I mean, for the listeners that are hearing us, many men think that we as surgeons, we fear scar tissue. And I'm like, I'm talking about revision surgery after revision surgery, I'm thinking about the complete opposite. It's like scar tissue keeps everything in place. I'm thinking, will the tissues be strong enough to withhold that implant inside? And these are things that patients really need to understand. Now, going back, we have the malfunction, then we have malposition. That's something during surgery happened in which the device wasn't able to be properly placed. Many men think that that's a synonym for malpractice, and I told them no, that you probably came in with difficult anatomy. If they had priapism, a history of priapism, if they have Peyronie's disease, again, these are people who have problems in their penis. If you have erectile dysfunction, just like you mentioned before, Larry, these are men that have a sickness inside their penis, most of the time, at least. And they have to understand that things are not going to be perfect. So there's malposition, and then the other one is patient dissatisfaction. Like they're just not satisfied most of the time, at least in my experience, is when they are not properly counseled or they just have completely misconception. They think they're going to get that Rolls Royce back.
Yeah. And those are guys who have a perfectly functioning implant and a great result, but are still dissatisfied. And that's a really interesting topic. Let's delve into that a little bit, because the research would suggest that people who have an implant, have satisfaction levels of upwards of 90 to 95% of patients are very satisfied with their implant, but that's not 100%.
Right.
So I find that some of those guys want the glands engorgement. We can treat the glands engorgement. People just need to know that we can do that. Are there other things that you find, like guys who are upset about their length or girth? So are there guys that they come in, they've had ED for 5-10 years. Are you prepping those guys with like a rehab protocol?
Absolutely.
Yeah. So talk more about that.
So what I tell them is like a good rehab protocol is vacuum erection device. The vacuum erection device, again, it sucks blood into the penis. You have to have a good amount of lube.
Can't use too much. That's not possible.
And you can, you press that thing against your pubic bone and you press on the button until, this is my protocol.
Yeah.
I tell them you're going to have the penis stretch out until it's uncomfortable, not painful, but uncomfortable. You keep it there for 10, 15 seconds. Relax. You do it again.
And just to clarify, this is a guy who comes in with ED that maybe wants an implant, but you want to prep him for the implant. So you're having him use a vacuum pump.
You're not doing that to everybody. You're not giving everybody the ED because not everybody wants it. Not everybody will do it.
Well, I offer it to every patient, especially if they're concerned about size loss.
Exactly. If they're concerned about size loss, I tell them the one thing you can do to help yourself, because the day of the surgery, you bring in a 18-wheeler, I put in an 18-wheeler. You bring me a Prius, you're getting a Prius. So it all depends on you and what you bring into the operating room. So one thing that you can do at home is use a vacuum pump.
Yeah.
For example, even a guy who thinks that they were undersized, and we have to go back because there's like a crossover or there's something else, I tell them the best thing you could do to optimize your size, even with an implant, is using a vacuum pump.
I've had that conversation with patients too. Do you ever have guys use a vacuum pump once they have an implant in?
No.
Yeah. So I actually have had some of those guys use a traction device, like the Restorex, and a vacuum pump. And I've actually had guys get benefit. Now, the risk there is if you're lengthening the penis, which is what you're hoping to do, then they might have an implant that's undersized, so they might need a revision.
I don't think it changes enough to...
I've seen improvements.
It depends.
Yeah.
It really depends. But one thing that men need to understand is like whatever they see in the vacuum pump is not necessarily what they're going to see with your implant.
Yeah.
So what I tell them is like us men, whenever we start using that vacuum pump and we start using it, we need to understand that we tend to have fat and skin on top of the pubic bone. So whenever you're using a vacuum pump, you're pressing all the way deep down into your pubic bone and looking at your penis stretching out all the way. So the way that I counsel them, again, it's all about counseling and education. I tell them what you see inside the vacuum pump might be what you use when you have sex, not necessarily what you will see once you get aroused. And I have same deal. I have a little album that is a patient who was graceful enough to show me his progress throughout his recovery after surgery. And he had a pre-surgical picture of him injecting himself, and you see his penis like very, engorged. And then after surgery, that looks like a little stump. And then 4 weeks, it looks a little bit bigger, but there's still swelling around the pubic bone. There's still swelling around the scrotum. Then 7 months when he's not aroused. Another thing that they need to understand is like the implant is flat. Is not round, right? So the shape of the penis is another big misconception that men get. So, well, doc, my penis used to be round. And
No, they can leave a little in.
I'm sorry?
They could leave a little fluid in if they don't like the flatness.
But when they're fully erect, if they're unaroused, because the sponge is not engorging.
Exactly. So if the urethra is not engorging, then it looks flat.
Yeah.
And I have, for example, I have a video on YouTube. It's like, why does my penis look flat with an implant? I try to explain to them the anatomy. It's like, hey, we're occupying the two spaces that are on the top of your penis. On the bottom, there's a urethra, and that depends on arousal. And And then with the vacuum pump, they need to understand that, hey, like this is not what you necessarily will see when you have an implant, is what you will use. Because when you penetrate, your partner will be creating pressure all the way deep down into your bone, because I know you want to get that last millimeter in. and that's usually what can help them.
Well, I love this very honest conversation. You know, I think especially when talking about surgery.
Is there anything else you want to share?
No, I'll tell you why I really like this conversation, because it doesn't sugarcoat anything. Because I find, you know, whenever I'm interviewing someone, especially when it comes to someone who's doing a lot of surgeries, I don't want to see all the pretty little pictures. Like, I want to know, what are the benefits? Who can you help? What are the risks? Because no surgery is a perfect surgery. And I think you give a really honest account from the perspective of a very busy surgeon who also offers comprehensive men's health care. You're selling health and comprehensive care. You're not selling an implant.
Absolutely.
And so I appreciate this honest conversation today.
Thank you.
Yes, did a great job. We loved having you.
Thank you. Thank you so much for the invitation.
I really enjoyed talking with Jonathan today. I think he gives like this real world perspective of all the different options we can offer to patients and doesn't sugarcoat it.
I know, but I loved his analogies.
Yeah.
I mean, I should have written them down, but, you know, with the wooden leg and the Mercedes or the Rolls Royce. I just think they're good, practical ways of explaining things to patient about an otherwise difficult subject.
Yeah. Do you have any of your own good analogies you want to share? You have none?
None.
I like the sponge analogy. And I actually, in my office, I have 2 sponges, and I show patients a sponge and I say, your penis is just like a sponge. And they get that, right? Like, it's just spongy tissue. It needs to engorge with water if you're doing dishes. It needs to engorge with blood to get an erection. And what I say is, you know, the purpose of me helping you get daily erections is like putting the sponge under the faucet every day, right? But if I say, look, I'm going to do dishes one day, I'm not going to do dishes, you know, again for another 6 months, what happens to that sponge? And they say, yeah, it looks pretty old and crusty. And I'm like, that's why it's important that we do things to help you get more frequent erectile function.
So that's you lead up to vacuum devices.
Yeah, that's where I'm going into like penile rehabilitation.
Yeah.
And they get that.
Yeah.
You know, they really understand that in real time. I'd say that's one of my favorites.
Yeah, I like having the in situ anatomical version of the pump in the office, so that patients can actually see where the pump sits, how it gets an erection without going through all the tubing and the connection, because that's scary, I think.
Yeah. Definitely good to have some demos and models in the office, for sure.
And patients, the names of patients who are willing to talk. I mean, that really helps.
Absolutely. All right, Larry, I'm going to put you on the spot here. Any final F words or final thoughts?
That a functional penis is a happy penis.
Okay, I love that. I would say my final thought is just like one of the messages that Jonathan was saying today is the question at the end of the day, and this is what I say to my patients as well, is not whether or not I can help restore your erectile function. I can do that. And that has to do with all the technologies and innovation over the last, like 50 years. But that's not the relevant question. The relevant question is, how do you want to be helped at this point in time? And for some people, you give them all the options, and there could be 5 to 10 options to restore their sexual function, and maybe none of them are resonating with them. That's okay, right? So there are some guys that we can't help if they don't want to, undergo any of those therapies.
Right.
But I would say,
but they're in your office for something,
right?
So not just there to talk,
right? So I would say it's rare that I can't get someone better if they're just willing to entertain some of these therapies, and I think that's awesome. I think that's what makes our job so special and so meaningful.
Yeah, but this is one of the few areas where we can almost guarantee a good outcome if they stick with it.
Yeah.
Unlike a lot of the fertility issues that we address, which are so frustrating.
Yeah, that's true. But I would also say that the interesting thing with erectile function is a lot of men come in and if they, Viagra, Cialis didn't work for them, they feel so desperate and they're like, are there any other options, right? So men need to know from actually a younger age than when they're coming in, we have options. So I think that's a really good final message there. All right, some foreplay for the next episode, Larry.
So, in keeping with today's theme, our next podcast will be with one of my patients who you will find delightful and the perfect follow-up to today's episode.
Awesome. I can't wait to meet him. Thank you for joining us today on fertility and other F words.
And don't forget to like, subscribe, and leave a comment.
Until next time.